Okay, everyone, so just going to run over the basics of renal function. So just here's a quick summary of what I'll talk about. Obviously, I'm not going to repeat everything that's in the packets, but just some basic principles that hopefully, if you review this video, it'll make learning the packets a little bit easier. So we'll go over some basic anatomy, some renal blood supply, and then we'll talk about the difference between dominant and recessive kidney disease, and then we'll talk about some renal stones, calculi, some UTIs, Wilms tumor versus renal cell carcinoma, and then acute kidney injury and chronic kidney disease. And we'll just talk about a brief summary of each one of these. So just a quick recap of some of the anatomy. Here we have the afferent arterial, and then the efferent arterial. And so these terms, afferent, efferent, are used here, and they're used with neurons and other things. And just think about the difference between affect versus effect. So if you do an action, then that has an effect. So the effect comes after your action. So the efferent arterial is going to come after the structure. Hopefully that isn't confusing and that helps a little bit. But the afferent arterial is going to be much wider than the efferent arterial, which is going to increase the hydrostatic or the pushing pressure inside the glomerulus. So if you think about it, it's like a giant hose going into the glomerulus and then this little straw coming out. So there's going to be a lot of pressure inside the glomerulus because not much is going to be able to come out. And so all of that pressure is going to be able to push fluids and electrolytes and other things into the glomerulus and into the nephron. Um, so the percent of plasma that ends up as filtrate is called the filtration fraction. So that's a good term to know. And also this membrane right here is permeable to water and electrolytes, but it should not be permeable to larger substances such as proteins. So if you have a lot of protein in the urine, then you know that something is wrong with the membrane right there. So we have two different kinds of nephrons. We have cortical nephrons, and these are short, thick loops. So for those who don't know Spanish, I'm sorry, but I think of this as corto, which means short. And there you go. You learned a little bit of Spanish if you didn't know it before. But cortical nephrons are thick and short, and then juxtamedullary are longer. So these ones are going to go deeper into the medulla, hence the name juxtamedullary. And so those ones, that's the big difference between those two. Right here, we have Bowman's capsule is going to be the outer edge of that claw, and inside of that is Bowman's space. So that's where the water and the electrolytes go from the glomerulus into the nephron. And so then as it comes down here, here's the proximal convoluted tubule. So convoluted does it means it's like all wound up. And so a large amount of filtrates such as amino acids, glucose, sodium, water are going to be reabsorbed here into the body outside of the loop. And then we go into the loop of Henle, which is this dip right here. And so here's something pretty neat is something called counter-current multiplication, which I hope sounds vaguely familiar from when you took physiology. But pretty much it's the body's way of creating a gradient in which the body can absorb more water. So on the distal ascending loop right here, we have ions that are actively being pumped into the outside, which increases the concentration out here. And in the proximal descending loop of Henle, the membrane is only permeable to water. And so if it's super concentrated out here from the ascending loop, and it's only permeable to water on the descending loop, that means that through osmosis, all of the water is going to be sucked out of the loop, or not all of it, but a lot of it is going to be sucked out of the loop and back into the body. So that's how the body maintains hydration, because the glomerular filtration rate is supposed to be 90 to 125 milliliters a minute, and we're not peeing all of that out. And so a lot of that is going to be reabsorbed in the convoluted tubules, but also in this loop of Henle. And so the gradient gets more extreme the lower you go. And more water is going to be able to be absorbed. So that is called countercurrent multiplication. Just some helpful background with this. Um, okay, and then the distal convoluted tubule is going to reabsorb other ions. And then two hormones that cause water and sodium absorption are aldosterone from the adrenal gland and antidiuretic hormone from the pituitary gland. So anti is like against, diuresis is urinating. So antidiuretic, it's going to maintain or retain water. Okay, so here we have autosomal dominant polycystic kidney disease. And this is what it looks like. I think Dr. Beckstrom showed you pictures in class. It's pretty intense looking, but it's evaluated through ultrasound, um, and it activates the ROS system, which I know you're learning about right now in pharmacology. So that increases the blood pressure, and it manifests in flank pain. So that's kind of pain in your flank is kind of like your like generally like your middle lower back, and blood in your urine, so hematuria. And then also it can cause cerebral aneurysms. And the reason for that is that the same genetic anomaly that causes cysts in the renal tubules causes ballooning of the vessels in your brain as well, which causes that aneurysm, which is a ballooning of the vessel. So ballooning in the kidney, ballooning in the brain, neither one is good. Okay, autosomal recessive polycystic kidney disease. This is much rarer, diagnosed earlier in life. And because it's diagnosed so early, if you just imagine the kidneys are getting so massive that the lungs cannot develop because there's no space for them. And so a lot of newborns and babies die from this, unfortunately, even though it is pretty rare. Okay, so now let's talk about some renal calculi. These are kidney stones. Men are more likely to get them than women. Many different factors for this. I guess we drink less water than women do. And so if you drink less water, you're more likely to get kidney stones. And we also eat more protein and salt. So that is just the facts as they stand. So just remember to drink water and don't eat too much protein, I guess. These are diagnosed by CT scan. And so we'll go from left to right here. So we have calcium oxalate stones. So these are associated with high calcium levels and low citrate levels. Um, because citrate is something that can help prevent kidney stones. So that's an important factor here. Oxalate causes the excretion of citrate from the body. And then struvite stones are due to infections, UTIs, and form in an alkaline environment, because the bacteria are breaking down urease, and so that causes it to be more alkaline. And these can become staghorn stones. And then I guess we kind of skipped. We'll go back to uric acid stones, caused by anything that increases uric acid in blood, and these are purine foods. So you're going to want to generally know what foods have purine in them, and they can also be caused by gout and chemotherapy, because chemotherapy is going to lyse or break apart tumors, and that's going to release different factors into the bloodstream, which are going to go down, be filtered by your kidneys, and it's going to cause the accumulation of uric acid. So that's why chemotherapy can cause that. Cystine stones caused by rare genetic abnormality. They're the least common, I believe. And they manifest as a colic, which is like a sharp intermittent pain, or non-colicky pain, which is like a dull ache. So those are the different kinds of pain that can manifest with kidney stones. Okay, UTIs. Um, Cystitis is a lower UTI. So that's like the bladder. Pyelonephritis is going to be upper UTI. So that's like the ureters and the kidneys. So just remember, like anything that introduces bacteria or kills protective bacteria puts you at an increased risk for UTI. So some examples of this from the packet is sex, catheters, intestinal fistula, which is a space that shouldn't be there. So like if for whatever reason like your bladder um and your bowel were to not have a space between them, then obviously lots of bacteria from your bowels are going to be introduced into your bladder and into your kidneys. So that's not good. And then spermicides kill protective bacteria. So if you just remember that principle, hopefully the rest of it makes sense. Okay, so we have two kinds of malignant tumors in the kidneys. So we have Wilms tumor, mainly found in children, manifested by gross hematuria, which is blood in the urine, and it is treated by chemotherapy. And then we have renal cell carcinoma, which is mainly manifested in adults, and some risk factors for this are smoking, obesity, so some preventable things. And the treatment there is surgical resection, so getting rid of the tumor through surgery. Okay, so here we have acute kidney injury. So four stages. Um, onset phase, pretty much just when it starts. Oliguric phase is when you're urinating less, and then diuretic phase is as it's starting to heal, it kind of overcompensates and you urinate more, and then recovery gets back to the normal. So you can either have pre-renal, renal, or post-renal. So some examples of pre-renal kidney injury could be from like anything that happens before it gets to the kidneys. So for example, if you have hypovolemia or less fluid in your blood, then that's kind of a something that would happen or occur before it gets to the kidney, and that would affect the kidney. And then renal could be like an infection of the kidney, something that's happening inside the kidney that would affect urine output. And then post-renal is an obstruction. So if you have BPH or enlarged prostate or something else that's obstructing urine flow, that would be considered post-renal kidney injury. Okay, then chronic kidney disease. This is manifested as high BUN, fluid imbalances, because your kidney is not able to filter those things, which is normally what it does. So definitely looking at the BUN. Also creatinine. I don't know specifically creatinine for this one, but those are signs that your kidneys are not working as they should be. So live a healthy lifestyle. She mentioned specifically don't drink as much cola. I know she talks about that for a little bit. And if you have a glomerular filtration rate of less than 15, then you need to be on dialysis, because remember, the normal is 90 to 125. Okay, hope this is helpful.